Welcome back to our lecture series on basic ECG for beginners. In our last lecture, we looked at rhythms which were generated by the SA node, which is what you expect the normal pacemaker of the heart to be. If you accidentally skip that lecture, it is worthwhile to review that lesson before moving into this one. In this lecture series, we're going to look at rhythms which originate from the atriums of the heart. In this installment of the series, we will be taking a look at rhythms coming from the atriums, which are namely premature atrial contractions, or PACs in short, atrial flutter, and also atrial fibrillation. Due to the inherent automaticity of the cardiac cells, aside from the normal SA node as the pacemaker, other locations in the heart may also propagate impulses. Cardiac rhythms generated by impulses from different locations of the heart will have its own distinct and unique characteristics depending on the nature and physiology of the impulse propagated. As such, the key in mastering ECG interpretation is building a strong foundation on electrophysiology and understanding the concepts rather than memorizing the characteristics of each of these rhythms, which could be a handful. Foremost, let's take a look at what premature beats are. Premature contractions are also known as extrasystole or ectopic beats, or sometimes called ectopic complexes. Groups of pacemaker cells throughout the conducting system are capable of spontaneous depolarization. Ectopic impulses from subsidiary pacemakers are normally suppressed by more rapid impulses coming from above. However, if an ectopic focus depolarizes early enough before the arrival of the next sinus impulse, it may capture the ventricles, producing a premature contraction. Much like how a premature infant comes before its estimated time, premature beats come earlier and before the next expected sinus beat in a normal rhythm. Premature contractions, or ectopics, are classified based on where they originate from. For example, premature atrial contractions, or PACs, are ectopics which originate from the atriums. Premature junctional contractions, or PJCs, are ectopics coming from the AV junction. Premature ventricular contractions, or PVCs, on the other hand, are extrasystoles which originate from the ventricles. Each of these premature beats can be easily identified based on their unique characteristics due to the nature of where these impulses are generated from. Let's take a look at this first one. PACs will have upright facing P waves, but when compared to their normal sinus rhythms, their P waves differ in morphology, but they both precede a narrow QRS. PJCs, on the other hand, would have retrograde Ps or upside down Ps or no P waves at all, preceding a normal narrow QRS. PVCs would be easily identified by their prominently widened and bizarre QRS waves. We will go into the details of these characteristics of PJCs and PVCs when we cover rhythms originating from the AV junction and ventricles respectively. For now, let's focus on premature atrial contractions, or PACs. It is worthwhile to note that PACs occur only occasionally within a normal underlying rhythm and may not follow a regular pattern of occurrence. This causes an irregularity within the rhythm strip. The rate would then be highly dependent on the underlying rhythm and may be within a 60 to 100 beat per minute range for a normal sinus rhythm. P waves for a PAC is present and faces upright but differs in morphology when compared to other normal sinus P waves within the same rhythm strip. This is one of the key characteristics of a PAC. The next key characteristics of a PAC is that it precedes or occurs before a QRS complex. The QRS complex in this case is expected to be narrow and within the normal duration of 0.12 seconds or less, as this rhythm or impulse is depolarized from above the ventricles. QRS waves are only widened when the impulse originates from below, which is i.e. the ventricles. PR intervals would be normal in sinus beats, but it may vary when it comes to the beat involving the PAC. Now, let's try interpreting this rhythm strip using our 6-step analysis approach. Using the 6-step analysis approach, we first need to determine whether our rhythm strip is regular or irregular. While at first glance, this rhythm strip seems obviously irregular, it is always good practice when you are starting out with ECG interpretation to approach this manually using our 6-step approach, as some rhythms which you may come across later would be harder to ascertain its regularity, especially when rhythms are faster and beats get closer to each other. So first of all, grab a piece of paper, align the edges against 2 or 3 normal beats, and mark off the R to R intervals. Next, move your markings down the rhythm strip to check if all the R waves fall regularly on your marks. Here, we see that one of the beats does not fall on the mark. But what exactly is happening? Let's analyze this for a second. The next expected sinus beat is supposed to occur here, where the blue line is, but instead, this beat seems to have occurred earlier than expected. This is what you call as a premature contraction. So go ahead and mark that off. Continue down the rhythm strip to look for more irregularities. Here, we find another premature beat which comes earlier than expected in a normal sinus rhythm. So go ahead and mark that off as a premature contraction. We have just identified 2 premature contractions in this rhythm strip. We will need to identify where these premature beats originate from later. In essence, premature contractions are, as what the name suggests, beats that come earlier than they are supposed to. Very much like how babies are born before their expected date of delivery are called premature infants. Following each premature beat, you will also notice a longer than usual pause before the normal rhythm resumes its rate. This is called a compensatory pause. The next step is to calculate the rate of the rhythm. Because this rhythm is irregular, we will not be able to use the 300 or the 1500 formula, as the R to R intervals vary in an irregular rhythm. With that considered, we will go ahead and count the number of R waves within a 6-second strip and multiply that with 10. Here, we have a 6-second strip with 30 big boxes and 8 R waves within that rhythm strip. As such, we have a rate of 80 beats per minute. Next, let's analyze the P waves. You want to scan through the entire rhythm strip to analyze and compare all the P waves that are present in this rhythm strip. Here, we can see that all the P waves are positively deflected, or simply put, they are all facing upright as they should be. You will also need to look at the morphology or shape of each of the P waves in this rhythm strip. Here, we can see nice, rounded, and uniform P waves indicating sinus beats. Unfortunately, the same can't be said about the P waves in the premature beats identified earlier. You will notice that their morphology or shapes are different from the P waves in the sinus beats. However, they're all still upright facing. This tells us that they originate from the atriums. Now, how did we come to that conclusion? Simply put, when a beat originates from the same foci, you will expect that all the children's of that foci to look the same and have the same features. They can't be from the AV junction because we will see later that rhythms that come from the AV junction will have upside down or negatively deflected P waves or P waves which are hidden under the QRS. Lastly, they can't be from the ventricles because rhythms originating from the ventricles will have a widened and bizarre QRS. As such, we can conclude that these two ectopics here are indeed premature atrial contractions or PACs. Our next task is to calculate the QRS interval. To do this, simply draw downward lines at the beginning and the end of the QRS wave and count the number of small boxes in between them. Here, we see that the QRS intervals are consistently 2 small boxes wide across the strip. As such, the QRS interval is 0.08 seconds. The normal QRS interval is 0.12 seconds or less. As such, this QRS in these rhythm strips are regarded as narrow. Something to keep in mind is that narrow QRS interval also tells us that this rhythm originates from above the ventricles. QRS waves which are wider than 0.12 seconds indicate that the rhythms originate lower down the heart, i.e. the ventricles. Next is a very simple analysis. Here, we just want to determine a pattern in the P and the QRS relationship. Here, we can see that every P precedes the QRS. The last part of the 6-step analysis is to measure the PR intervals. In this case, the PR intervals for both the sinus beat and the premature beats are 0.16 seconds, which is within the normal PR interval range of 0.12 to 0.20 seconds. Finally, to interpret the rhythm in this strip, we identified that the strip shows 2 premature atrial contractions. However, that statement alone does not describe this rhythm strip in its entirety. We have to next describe the underlying rhythm. To describe the underlying rhythm, we need to review the findings of our 6 questions. The rhythm strip is irregular because of the presence of the PACs. If the PACs were not present, we would in fact have a regular rhythm. Sinus Ps precedes each QRS with normal PR intervals, which tells us that the underlying rhythm is in fact sinus. At a rate of 80 beats per minute, the rhythm is not tachycardic nor is it bradycardic. As such, we can conclude that the underlying rhythm is a sinus rhythm. When interpreted together, this rhythm strip shows a sinus rhythm with 2 premature atrial contractions. When interpreting rhythm strips, it is necessary to review the findings of the 6 steps of the rhythm analysis. Missing any points could lead to a wrong interpretation. Here is how a rhythm strip with PACs look like on a cardiac monitor. On a moving strip, you will not need to count the number of PACs as we will not know how many PACs will be occurring further down the strip. You will only state the number of PACs when you are presented with a static or printed ECG strip. Moving on, let's look at another rhythm which is called atrial flutter. Atrial flutter is a type of supraventricular tachycardia caused by a re-entry circuit within the right atrium. In a normal sinus rhythm, only one atrial contraction will follow one ventricular contraction in an organized fashion. But in atrial flutter, the focus within the right atrium is firing repeatedly and consecutively in circles making the atriums to contract at a really fast rate. The length of the re-entry circuit corresponds to the size of your right atrium, resulting in a fairly predictable atrial rate of about 300 beats per minute and may range between 200 to 400 beats per minute. The AV node, however, which relays the impulses down to the ventricles, is not capable of doing so at such a fast rate, and it would be disastrous for the ventricles to beat faster than 300 beats per minute. As such, the AV node creates a sort of physiological block to limit the number of impulses which is sent down to the ventricles. This is where you will notice that there are multiple P waves preceding each QRS. In a common atrial flutter with a fixed AV block, you would expect a regular P to P interval indicating atrial rate and a regular R to R interval indicating ventricular rate. Atrial flutter, however, can also present as an irregular rhythm when there is a combination block present. We'll be looking at this in more details in a while. Atrial rates are around 300 beats per minute, while ventricular rate is usually 150 beats per minute or less, depending on the degree of AV block. The more higher the AV block, the lesser the ventricular rates will be. Because there are multiple atrial contractions preceding ventricular contractions, P waves in atrial flutter will be replaced by this distinguishable sawtooth or flutter waves. As this rhythm originates from above the ventricles, QRS complexes are still expected to be narrow and within the normal QRS interval of 0.12 seconds or less. PQRS relationship will depend on the AV block ratio and will vary in a combination block. PR interval in this case is no longer applicable. Here is a short animation which explains the physiology of atrial flutter.
Your heart. It pumps blood around your entire body, coordinated by an incredible electrical system. Normal heartbeats begin when your SA node fires an electrical impulse. This makes your atria contract, forcing blood into your ventricles. When the impulse reaches your AV node, it pauses before moving through your ventricles. This makes your ventricles contract, forcing blood out of your heart and around your body. If you have atrial flutter, the electrical impulses circulate much faster than normal around your atria. This makes your atria contract much faster than they should, up to 300 times a minute. To control your heart rate, your AV node often blocks some of these impulses. This causes your atria and ventricles to pump at different speeds, putting your heart under strain and increasing your risk of stroke.
In atrial flutter, a group of foci within the atria emits impulses consecutively in a circular fashion, activating the atria at a rate of 300 times per minute. The baseline of the ECG consequently becomes all P waves, giving it a sawtooth appearance, thus much more accurately called flutter waves instead of P waves. You will also notice that the flutter waves morphology is evenly similar across the rhythm strip because the foci points which are emitting the impulses are constant. In normal rhythms, every atrial depolarization will be followed by a ventricular depolarization, resulting in a QRS wave. But in the case of atrial flutter, where the atriums are firing at a rate of 300 times per minute, the AV node sets a physiological block to only allow some impulses to flow through and activate the ventricles. If the AV node sets a 2-in-1 block, then the atriums will contract twice, followed by one ventricular contraction. If the AV node sets a 3-in-1 block, then the atriums will contract 3 times, followed by one ventricular contraction. If the AV node sets a 4-in-1 block, then the atriums will contract 4 times, followed by one ventricular contraction. If there is a variable block present, then there will be alternating mix of 2-in-1, 3-in-1, or 4-in-1 blocks across the rhythm strip, which cause the overall rhythm to become irregular. Now, let's use our 6 systematic step approach to analyze this rhythm strip. Let's start with rhythm regularity. We can see that the R to R intervals, which signifies ventricular rate, is regular. In atrial flutter, you may also check the regularity of the P to P intervals, which signifies atrial rate. Here, we can see that the atrial rate is also regular. Because this rhythm is regular, we will calculate the ventricular rate using the R to R intervals. Here, we see that there are 3 boxes separating the 2 R waves, which gives us a ventricular rate of 100 beats per minute. In atrial flutter, we are also interested in calculating the atrial rate by measuring the P to P intervals. Here, we have 1 box separating the 2 P waves, which gives us an atrial rate of 300 beats per minute. Next, let's look at the P waves. What we can see are multiple P waves preceding each QRS wave, making what is known as a sawtooth pattern. Specifically, we can see 3 P waves preceding each QRS wave. This tells us that the atriums are contracting 3 times for every 1 ventricular contraction. This means that there is a 3-in-1 AV block. It is sometimes tricky to identify the number of P waves present in an atrial flutter, as a P wave can become embedded or hidden within a QRS complex which has a greater amplitude, as seen here. You can see the remnants of a P wave embedded within the QRS because the QRS is a much bigger wave, i.e. higher amplitude. Earlier, I emphasized the need to measure both the atrial and ventricular rate in an atrial flutter. Well, this is where it will come in handy. To identify the degree of AV block, the ventricular rate is usually a fraction of the atrial rate. In this rhythm, we see that the atrial rate is 300 beats per minute and the ventricular rate is 100 beats per minute. This gives us a ratio of 3:1. As such, as a rough guide for fixed AV blocks, a 2:1 block will give a ventricular rate of 150 beats per minute, and a 3-in-1 AV block will show a ventricular rate of 100 beats per minute, and a 4:1 AV block will have a ventricular rate of about 75 beats per minute. The next step we have to tackle is to measure the QRS interval to know if the QRS complex is narrow or wide. In this case, the QRS interval measures 0.08 seconds, which is within the normal range of 0.12 seconds or less. As such, these are narrow QRSs in the rhythm strip shown here. Do bear in mind that narrow QRS complexes tells us that this rhythm originates from above the ventricles, and we can rule out ventricular rhythms. Next, we will look at the PQRS relationship. As established earlier, there are multiple P's preceding each QRS in this rhythm strip, which we will refer to as flutter waves due to the nature of the sawtooth pattern it produces. Because the P waves in an atrial flutter have been replaced by flutter waves, measuring the PR interval is no longer applicable. Finally, from the findings of the 6-step analysis approach, we can summarize that due to the presence of a narrow QRS from the rhythm strip below, this rhythm originates from above the ventricles and we may rule out all ventricular rhythms. The presence of flutter waves preceding each QRS allows us to rule out the possibility of the rhythms coming from the SA node or the AV junctions. As such, it has to be an atrial flutter. Further analysis of the flutter wave tells us that there is a 3-to-1 AV response, which leaves us with the final interpretation that the rhythm is indeed an atrial flutter with a 3-to-1 AV block. Here is how an atrial flutter with 3-to-1 AV block looks like on a cardiac monitor. Let's now take a look at this next rhythm, which has a very similar feature as the previous one. We once again observe flutter waves. This time, however, we can see that there are more sawtooth waves preceding each QRS. More specifically, there are 4 flutter waves. To confirm our claims, we can quickly measure the atrial and ventricular rates to obtain a ratio. The P to P interval is measured as one big box, which makes the atrial rate 300 beats per minute. The R to R interval is measured at 4 big boxes, which makes the ventricular rate at 75 beats per minute. When taken together, this gives us an atrial flutter with a 4-to-1 AV block. When analyzing atrial flutter with a fixed AV block, do use the atrial ventricular rate fraction ratio as a guide. Generally, 2-to-1 AV blocks will produce a rhythm rate of about 150 beats per minute. A 3-to-1 AV block will produce a rhythm rate of about 100 beats per minute, and a 4-to-1 AV block will produce a rhythm rate of about 75 beats per minute. Here is how an atrial flutter with 4-to-1 AV block looks like on a cardiac monitor. Here is another variation of atrial flutter. In this rhythm, we see that there are flutter waves, but the rhythm is irregular when compared to the previous atrial flutters we have just seen. Instead of having a fixed AV block of 2-to-1, 3-to-1, or 4-to-1, which makes the rhythm regular, this particular rhythm has a pattern of varying ratios of block. In this case, this is called an atrial flutter with combination or atrial flutter with a variable AV block. This is different from an atrial fibrillation or AF, which we will learn about in just a while. While this rhythm is irregular, there is still a predictable pattern of irregularity, which in ECG terms is called regularly irregular. Here is how an atrial flutter with a variable AV block looks like on a cardiac monitor. Atrial fibrillation, which is also called AFib or AF in short, is characterized by disorganized atrial electrical activity and contractions. In AF, irritable foci all over the atria causes rapid action potentials that result in rapid atrial rates of between 400 to 600 beats per minute. These erratic impulses causes the atria to not be able to contract normally and only shiver or quiver, thus the term fibrillation. Because these impulses emitted by the atria are so rapid and erratic, there is no fixed rate at which the AV node will allow conductions to pass through to the ventricles. This in turn causes the overall rhythm to be chaotically irregular with no predictable or discerning pattern. A term used to describe this irregularity is irregularly irregular. Heart rate in AF vary widely. Rates of below 100 beats per minute are called controlled AF or just simply AF. AF with rates above 100 beats per minute are called uncontrolled AF or more commonly fast AF. In AF, PQRS relationships and PR intervals are no longer applicable as the baseline is replaced by fibrillatory waves. Here is a short animation explaining the physiology and complications of AF.
Atrial fibrillation, or AF, is an irregular heartbeat. It is caused by a breakdown in the natural pacemaker that is responsible for making sure that the 4 chambers of the heart contract in a coordinated way to pump blood around the body. Under normal circumstances, the pacemaker first makes the 2 chambers at the top of the heart, called atria, contract, squeezing blood into the 2 lower chambers, also known as ventricles. These in turn are triggered to contract, pushing blood out of the heart, into the arteries, and out to the body and the lungs. In AF, a malfunction of the pacemaker interrupts this coordinated sequence of contractions, causing the atria to twitch erratically, known as fibrillation, and the ventricles to contract more often and irregularly. In AF, the heart works less effectively as a pump, with the result that there are areas within the heart where blood flow is slow or stagnant. Where this happens, blood clots can form, and these account for the increased risk of stroke associated with AF. The problem with a blood clot in the heart is that some or all of it can break away and travel along an arterial highway directly into the brain. As the blood vessels branch and become ever finer, at some stage the clot or fragment of clot is going to be too large to progress any further and will block the vessel in which it is travelling. This means that the surrounding area of the brain can no longer receive oxygen delivered by the blood, causing the nerve cells to stop working and ultimately die. This complication is called a stroke, or more precisely, an ischemic stroke. Because clots that form in the heart may be quite big, they can block wide vessels that supply large areas of the brain. Consequently, strokes arising from AF may often be fatal, or can cause temporary or permanent disabilities, depending on how long the oxygen supply to the brain is interrupted and which part of the brain was affected.
Causes of AF may include ischemic heart diseases, hypertension, valvular heart diseases, acute infections, electrolyte disturbances, especially hypokalemia and hypomagnesemia, thyrotoxicosis, some drugs, pulmonary embolus, pericardial disease, acid-base disturbance, and cardiomyopathies. A fast AF or a new onset AF is considered a medical emergency and should be reported immediately. In AF, you have to remember that the atria are not fully contracting but merely quivering. This causes blood in the atria to pool, stagnate, and leak down to the ventricles at an irregular and slow pace. In fast AF, where the ventricles are pumping at a higher rate, blood leaking through from the atria may not have the time to adequately fill the ventricles before it pumps. This causes the ventricles to pump whatever content is within them at that rate, causing a drop in cardiac output and ultimately resulting in a condition called shock. When a new onset AF is identified clinically, it should be reported to the physician immediately. From personal experience working in the emergency department, I have encountered a number of undiagnosed AF coincidentally during vital sign rounds. When I come across an irregular pulse rate, for example, I would normally check the patient's record for the most recent ECG. If the recent ECG shows no clues for an irregular rhythm, I would perform a stat ECG, which is where I would come across most new onset AFs amongst my patients. Patients with new onset AFs are at a higher risk of developing strokes. Due to the stagnant blood in the atriums caused by AF, blood clots are likely to form. These clots, if they come loose, can enter into the ventricles and later get pumped into the blood vessels where they travel to the cerebral artery and get lodged, causing tissue ischemia surrounding the blood vessels. Patients with new onset AF would most likely be started on anticoagulants like warfarin to prevent blood clot formations. Patients who present with new symptoms of stroke should also have their ECG recorded to rule out AF as one of the causes of stroke. Now, let's take a look at how to interpret an AF on a rhythm strip. Keeping with the 6-step analysis approach, we first look at rhythm regularity. Here we can see that the rhythm is irregularly irregular. We will then calculate the rate using a 6-second strip. Here we have a rate of 70 beats per minute. Looking at the P waves, there are no true P waves seen preceding the QRSs in this strip. Instead, the baseline is entirely replaced with a quivering and wriggly line, which we call fibrillatory waves. QRS complexes in this strip are still narrow and within the normal interval range of 0.12 seconds or less, which gives us the clue that this rhythm comes from above the ventricles. P-QRS relationship here is basically non-existent as there are no true P waves present. Instead, there is an irregular ventricular response following fibrillatory waves. PR interval can no longer be measured as well, as P waves are not present in this rhythm. With the answers to our 6-step analysis established, we can conclude that due to the narrow QRS waves, the rhythm shown here originates from above the ventricles. So we have 3 choices here. It could be either sinus, atrial, or junctional. We can exclude sinus because there are no true P waves present. Instead, the baseline is replaced with fibrillatory waves, so this tells us this rhythm is from the atria. The fibrillatory waves, which make the rhythm irregularly irregular, tells us that this is indeed an atrial fibrillation. At a rate of 70 beats per minute, which is under 100 beats per minute, this is then regarded as controlled atrial fibrillation or just simply atrial fibrillation. So, as we go along and understand more features of other ECG rhythms, we will be able to use this process of elimination like what we did here to identify and interpret ECG rhythms. Here is how an atrial fibrillation or AF will look like on a cardiac monitor. Now, let's try this again with this rhythm strip here. First of all, let's look at rhythm regularity. Rhythm here is obviously irregularly irregular. There are 13 R waves within the 6-second strip, which calculates to a rate of 130 beats per minute. There are no true P waves seen, but instead fibrillatory waves are present and preceding each QRS. QRS interval here is measured to be 0.12 seconds, so they are narrow and within the normal interval range. There is basically no PQRS relationship and PR interval is no longer measurable. As such, we can conclude that due to the narrow QRS waves, the rhythm shown here originates from above the ventricles. So again, we have three choices, either sinus, atrial, or junctional. Like before, we can exclude sinus because there are no true P waves present. Instead, the baseline is replaced by fibrillatory waves, which tells us this is indeed an atrial fibrillation. At a rate of 130 beats per minute, which is above 100 beats per minute, this is then regarded as uncontrolled AF or fast AF. Here is how a fast AF would look like on a cardiac monitor. To summarize our lesson, we covered three rhythms originating from the atria, which were PACs or premature atrial contractions, atrial flutter, and atrial fibrillation or AF. Let's now recap on the key characteristics of these rhythms. PACs are basically ectopic beats occurring prematurely before the next expected normal rhythm. Premature beats may come from either the atria, AV junction, or ventricles. But PACs have upright facing P waves which are just morphologically different when compared to sinus P waves. Their QRS waves are narrow and an ectopic is often followed by a compensatory pause before resumption of the normal underlying rhythm. Atrial flutters are prominent for their sawtooth flutter waves. They are commonly regular with fixed AV blocks, but may also present as an irregular rhythm with variable blocks under rarer circumstances. They are different from AF as their beats are morphologically similar from beat to beat. Because this rhythm originates from the atrium, which is above the ventricles, it will have narrow QRS waves. The degree of AV block in an atrial flutter can be guided using the atrial to ventricular rate ratio calculation. Last but not least, AFs are prominent for their highly irregular rhythm which has no fixed predictable pattern. The wriggly fibrillatory waves are also another key feature of AF.